Welcome to week 5 of your Master's in Traumatology from the University of Newcastle. My name's Gordon Doig. I'm located at the University of Sydney, and I'm going to be talking about nutrition support in the major trauma patient. Before we begin, here are my potential conflicts of interest. I'm not going to be talking about any products from any of these companies today, but to be transparent, it's important for you to understand that I am an academic researcher who does receive research support from industry for certain projects. These are the 4 key papers that I want you to obtain from your course coordinator. All 4 of them are interesting and essential reads. So, to give you some idea of what we're going to go over in this talk, I'm going to give you a context for the background as to why nutrition support is important in these patients. We're going to go over a review of the most recent direct clinical evidence. Then we're going to generate concise clinical recommendations and summarize by ending with some additional talking points. So, to provide you with some context as to where we come from in this field. In 2008, my colleagues and I published the results of a complex process that resulted in the development of evidence-based guidelines for nutrition support in critically ill patients. We developed these guidelines and we evaluated them in a 27-hospital clinical trial and published them in the Journal of the American Medical Association. This is important because I want you to understand to develop these guidelines, we went through all available evidence in this field. We conducted an exhaustive Medline and Embase search that identified 2,287 abstracts. We read these abstracts and retrieved 465 full-text papers for detailed evaluation. The detailed review of these papers identified 111 clinical trials that were conducted in critically ill patient populations and reported patient-centered, clinically meaningful outcomes. Based on our interpretation of these 111 clinical trials, our guidelines panel developed a very simple clinical practice guideline with 11 explicit recommendations. These recommendations are summarized in this algorithmic presentation of the guideline. You can come back and freeze this talk here or come to our website and get a detailed copy of this guideline. But essentially what I want to emphasize is the most important clinical recommendation that we could make based on our review of these clinical trials was for early enteral nutrition. Enteral nutrition to be commenced within 24 hours of ICU admission. So this is an enteral nutrition and early enteral nutrition centric guideline. This is important because it turns out that the most important intervention that we can do to support the nutritional requirements of our trauma patients who try our ICU care is also early enteral nutrition. And indeed, our very first clinical trials on this topic come from the mid-1980s and were conducted by trauma surgeons. Ernst Moore, that you see as the lead author on this paper, is a highly respected trauma surgeon from Denver. And indeed, if you go back in the literature even further to the 1970s, trauma surgeons were looking at this concept of sequential organ failure, which turned into multiple organ dysfunction, is the name that we use for it in the ICU today. But trauma surgeons proposed that in the critically ill patients they see with either a major infection or major trauma, they often require mechanical ventilation due to respiratory failure within 24 hours of their surgery. This requirement for mechanical ventilation is often followed by sequential organ failure that includes renal failure, hepatic failure. They identified gastrointestinal failure and metabolic failure also as very important stages in this process. So from the earliest conception, our concept of multiple organ dysfunction syndrome has always included GI and metabolic failure. So this is why trauma surgeons started looking at early enteral nutrition. They wanted to see if they could address this GI and metabolic failure. Today, we have 5 major ICU guidelines that recommend early enteral nutrition. These guidelines come from Canada, the US, Australia, and New Zealand, Europe. Indeed, I'm not aware of any major national level guidelines for ICU patients that do not recommend early enteral nutrition. So now let's specifically look at the field of trauma. The most current guideline that I'm aware of in this field was published in 2004 from the Eastern Association of the Surgery of Trauma, and it explicitly recommends that enteral feeding can be instituted in most patients after resuscitation is complete and hemodynamic stability has been gained. So what we need to understand is where this qualified recommendation comes from. Why do we recommend within 24 hours in ICU patients? But this trauma guideline qualifies that enteral nutrition should be started after resuscitation is complete. So let's look at our direct evidence from trauma patients. This is going to take you to one of your four key papers that I recommended earlier. It's a meta-analysis of randomized controlled trials conducted in adult trauma patients requiring intensive care. It specifically looks at standard enteral nutrition begun within 24 hours of injury compared to standard care. And standard care in these patients ranges from oral intake at return of bowel sounds, enteral intake at return of bowel sounds, or TPN or TPM plus delayed enteral nutrition. We leveraged off the literature search supporting our 2008 JAMA guideline, and we updated it to 2011, which is the time that we published this paper, and we expanded it with a specific focus on trauma patients. So here's the flow of papers that we identified. Our search identified 701 full-text publications for retrieval. 33 of these papers turned out to be randomized controlled trials evaluating the timing of enteral nutrition. However, the vast majority of these clinical trials were conducted in critically ill patients, with trauma included, but the trauma was not reported separately, so they couldn't contribute to our meta-analysis. An additional 4 clinical trials did not report mortality, 4 evaluated immuno-enhanced enteral nutrition, and 1 did not commence enteral nutrition within 24 hours. So it defined early as within 48 hours. This leaves us with 4 eligible randomized controlled trials for inclusion in our meta-analysis. This is a complete description of the patient populations that were included in this meta-analysis, the early EN intervention, including starting rates and targets, and the control nutrition intervention that included sometimes just 5% dextrose to return of oral intake, or enteral nutrition begun later. The primary analysis of this systematic review was based on randomized controlled trials that are methodologically sound. There was only one clinical trial that we identified that had a major flaw, and this is the clinical trial conducted by Moore et al. It enrolled 75 patients, but 12 of them just disappear. We don't know which groups these 12 patients were randomized to. We're specifically told that 4 of these patients die, so we don't know which group they belong into. So this gives us excessive loss to follow-up. Acceptable loss to follow-up is approximately 10%, so this is well over 10% loss to follow-up. Our 3 clinical trials that do not have major flaws, that were conducted in trauma patients that look at early enteral nutrition, when we combine them and conduct a meta-analysis, we can see that there is a statistically significant reduction in mortality attributable to early enteral nutrition. And we confirm this by bringing Moore's paper back into the picture. So here we have the Moore clinical trial that we just talked about. It has 16% loss to follow-up. We wanted to base our primary conclusion on clinical trials without major flaws, but when we look at all clinical trials that address this question, we can see that our statistically significant reduction in mortality persists. In these clinical trials, we also find that early enteral nutrition actually reduced the incidence of pneumonia, and there was a trend towards a reduction in the severity of multiple organ dysfunction syndrome. But perhaps most importantly, in these 4 clinical trials, there were no signs of any harms associated with the early use of enteral nutrition. Now, please go back to the previous slide where we look at starting rates. All of these clinical trials started enteral nutrition very early and gently and built up to their targets over a period of 2 or 3 days. So if you follow the processes used in these clinical trials, there is no ill effect from starting enteral nutrition early. Let's look at the indirect evidence for early enteral nutrition. And we're going to focus on upper GI surgery because many trauma patients have GI surgery, so this is relevant. This is a meta-analysis comparing randomized controlled trials of early feeding within 24 hours versus standard feeding in patients undergoing elective upper GI surgery. These authors identified 13 randomized controlled trials that included 1,137 patients. Early feeding resulted in a significant decrease in mortality. Early feeding was not associated with any sign of harms. And here you can see there's no indication that wound infections are increased. All these patients have bowel surgery. There's no evidence of an increase in dehiscence and no evidence of an increase in pneumonia. These authors conclude that there is no obvious benefit for keeping patients nil by mouth after gastrointestinal surgery. Now let's look at a special case, and this is becoming more and more popular in major trauma centers, and it's the management of leaving the primary laparotomy wound open so that the patient can be appropriately managed at a reoperation. So patients can be managed in the ICU with an open abdomen for a number of different reasons. And one of them is, just as I just described, reoperation, plan for damage control surgery, or management of severe abdominal infection. Also, patients in the ICU can get abdominal compartment syndrome. The abdomen can be open and they can be managed with an open abdomen for a period of time in the ICU. These aren't necessarily trauma patients. And less commonly, an abdominal surgery wound can dehiss based on infection or a number of bad complications. But we're going to focus on planned reoperation for damage control surgery. But first of all, let's look at some of the dogma surrounding the provision of nutritional support to these patients. So clinicians are concerned about feeding patients with an open abdomen because they fear bowel edema and ileus with subsequent aspiration pneumonia. They fear causing small bowel necrosis by stressing an underperfused bowel, and they fear increasing bowel distension, making it harder for the surgeon to obtain fascial closure. Therefore, many patients with open abdomen receive no nutrition support until fascial closure. So our question is, should we fear enteral nutrition in these patients? This is a brilliant study published in 2012. It's an observational study reviewing 597 trauma patients from level 1 U.S. trauma centers who were managed after their initial trauma surgery with an open abdomen. The average age of these patients was 38, 77% of them were male. The majority had blunt trauma with a very high injury severity score. There was an overall 14% mortality rate, and these patients on average spent 31 days in hospital. This is a pure major trauma patient population. 92% of the patients in this study were managed with an open abdomen after initial damage control surgery. 8% were managed with an open abdomen after abdominal compartment syndrome. 49% of the entire population had a full thickness bowel injury that required a direct repair, anastomosis, or colostomy. 39% received EN before first attempt at closure of the abdomen. So the vast majority of these patients are never fed before closure. We want to see what happens to the patients who are fed before closure. on intention to treat analysis for all 597 patients. And this is very important. This is an observational study, so we need to control for confounders. The authors conducted an appropriate statistical analysis that controlled for hospital, injury severity score, mechanism of injury, whether or not the closure attempt was a second laparotomy or a first laparotomy, total 24-hour infused volume of fluids, and presence of bowel injury. So after statistically controlling for all these factors, patients who received EN before first attempt at closure experienced significantly higher ultimate fascial closure rates. There was no difference in complication rates, and there was a significantly lower mortality in the patients who received enteral nutrition before first attempt at closure. So by every measure, receiving enteral nutrition before attempt at closure resulted in significant improvements in outcome. To be thorough, there are 3 other smaller observational studies that look at the provision of enteral nutrition in patients who are managed with open abdomens. And compared with delayed feeding, enteral nutrition started prior to fascial closure in these 3 smaller observational studies was associated with reduced rates of pneumonia, higher rates of primary fascial closure, and lower rates of fistula formation. Plus, overall total hospital charges or costs were lower in the patients who received enteral nutrition early. There were no reported adverse events in any of these 3 studies associated with the use of enteral nutrition started prior to fascial closure. So clearly, there's a lot of dogma surrounding patients who are managed with the open abdomen, but the observational studies do not support paying attention and driving care based on these dogmatic beliefs. Next, let's look at a little bit of the physiology supporting the reasoning as to why our trauma patients might benefit from early enteral nutrition. These are 2 excellent reviews that I would strongly recommend that you obtain and follow up. They're written by people who are considered experts in the field. Steve McClave is one of the first authors on the US SCCM and ESPN guidelines for nutrition support, and Darren Hayland has done an awful lot of work in this field. Here we have in this second paper, even more relevant and even more interesting. This is Ernst Moore, whose paper we saw initially that was published in 1986, and this is his twin brother that he's co-authoring with Frank Moore. They are both trauma surgeons and they work in the same department, and both of them have done a lot of work in nutrition in trauma. So very simplistically, everyone agrees that when we become critically ill, if we don't feed the gut, we have shock. Over time, one of our primary physical barriers that protects us from infection in the gut, the tight junctions, become looser. The loosening of the tight junctions significantly increases the ability of the gut bacteria to migrate through the gut wall and be trapped in the Peyer's patches or actually go into the circulation. So the tight junctions looser over time. In addition to this, over time, from shock, non-feeding, and a number of other factors, we have reduced contractility of the gut that promotes bacterial overgrowth. This gut stasis, bacterial overgrowth, and loss of structural integrity leads to bacterial translocation even more than any one of these 3 factors separately. So the gut neutrophils in the Peyer's patches become primed. They release cytokines into lymphatic drainage and also may travel to distant sites. These primed neutrophils increase the overall oxidative stress, predisposing to infection and multiple organ dysfunction syndrome. Here's a story as told by the Moore twins. This is an interesting figure where we have in the middle here the gut containing all its gut bacteria. We have dual insults of shock and delayed enteral feeding, resulting in bacterial translocation. And also we have primed neutrophils and bacteria traveling to the Kuffner cells in the liver, which stimulates the release of prostaglandins that reduce immunity, immune modulating factors like IL-6 that increase stress, and TNF that can directly lead to acute tubular necrosis. And down at the bottom, we also have the same mediators being released from injured tissue and the bacterial translocation to injured tissues, fueling the cycle further. So these are two very interesting papers that deal with the physiologic response to critical illness and how nutrition support could improve outcome from critical illness or trauma. These are two additional papers that are also very interesting reads. Both are a little bit more complex, but both deal with the issue of how the gut drives multiple organ dysfunction syndrome. If you want to get a hold of these two papers, I would strongly recommend them. So in summary, there's direct evidence, randomized controlled trials conducted in trauma patients, and indirect evidence, randomized controlled trials conducted in patients who have upper GI surgery, observational studies, and physiology that supports the benefits of early enteral nutrition for trauma patients. Significant reduction in mortality, significant reduction in ventilator-associated pneumonia, and significant reduction in the severity of multiple organ dysfunction syndrome. So we make a recommendation that in trauma patients, enteral nutrition should begin within 24 hours of injury as soon as shock is stabilized. This is consistent with the recommendation from the Eastern Association for Surgery of Trauma. And interestingly, the randomized control trials contained in our meta-analysis tell you exactly what definition of stable shock that they used to commence enteral nutrition. You have two options based on these clinical trials. Use the shock index, which is the heart rate divided by the systolic blood pressure. And if the shock index is stable for 1 hour, resuscitation has been completed and you can commence feeding. So the shock index defines when active resuscitation is complete. The alternative approach is that when systolic blood pressure has been stable without the need for increasing doses of vasoactive agents, resuscitation has been complete and you can commence nutrition support. It's very important to understand that stable shock is not defined by weaning or removing vasoactive agents. In the clinical trials included in our meta-analysis, it was a very progressive definition of end of resuscitation. And these are the two working definitions that they used. So here's some assorted loose ends. Rates and targets. There's no good evidence to mandate specific rates or goals. In general, the clinical trials in our meta-analysis started slow and tried to achieve reasonable goals within 3 to 7 days of starting. They used either indirect calorimetry or equations to set goals on day 3. So either approach is appropriate. We do not recommend starting at full rates. We're very happy with 20 mils an hour. And if you look at the starting rates of the clinical trials in our meta-analysis, 20 or 30 mils an hour is entirely consistent with the intervention that they evaluated. Head trauma patients, they might be a special case, but there's mounting evidence that suggests we create gut dysmotility by feeding late. So if you're concerned about aspiration and aspiration pneumonia in this patient population, there is good clinical trials evidence that you can start with post-caloric feeding. It reduces ventilator-associated pneumonia, but the caveat is you cannot delay the start of feeding to wait for the placement of the post-caloric tube. Indeed, read the clinical trials in our meta-analysis, and you'll see that some of the trauma surgeons who did the early research in this field, they placed the feeding tube post-calorically at time of surgery. So this allowed them to start post-caloric feeding very early. Finally, and this is just an overall summary statement, the role of parenteral nutrition. If you are clearly concerned about starting enteral nutrition early because of subsequent scheduling of more surgery or other issues, then we have large-scale clinical trials that clearly demonstrate parenteral nutrition does not increase infectious complications in this patient population. This is a large-scale clinical trial we conducted in Australia. Trauma patients were a part of this clinical trial. Outcomes were not reported separately, but it provides convincing evidence that you can start parenteral nutrition in this patient group. So thank you very much for your time. I hope you found that useful, and I hope you get some information out of the 4 papers that you're going to get from your course coordinator.